Percent depth dose, or PDD, is a fundamental concept in radiation therapy. It describes the amount of radiation dose deposited at various depths within a patient or phantom relative to the dose at a reference depth, typically Dmax. Dmax represents the depth at which the maximum dose is deposited. Understanding PDD is crucial for treatment planning, allowing clinicians to predict and control the distribution of radiation dose within the patient's body. This ensures that the tumor receives a sufficient dose to effectively kill cancer cells while minimizing the impact on surrounding healthy tissues. As a beam of photons enters a medium like water or soft tissue, which simulates the human body, complex interactions occur. Initially, the dose increases with depth, reaching a maximum at Dmax. This build-up region is attributed to the production of secondary electrons, which deposit their energy further downstream. Beyond Dmax, the dose decreases exponentially with depth, primarily due to the attenuation of the photon beam through interactions like photoelectric absorption and Compton scattering. The percent depth dose, or PDD, for a given photon beam is not constant, but varies depending on several factors. Understanding these variations is critical for accurate dose calculations and treatment planning in radiation therapy. One of the most significant factors affecting PDD is the energy of the photon beam. As beam energy increases, the depth of Dmax also increases, meaning the maximum dose is deposited deeper within the patient. This is because higher energy photons have a longer range in tissue. Field size, defined as the area irradiated by the beam at the patient's surface, also influences PDD. As field size increases, so does the PDD at a given depth. This effect is primarily attributed to increased scatter radiation from the larger treatment volume. Scatter radiation contributes to the dose at off-axis points, leading to higher PDD values for larger field sizes. Another crucial factor is the source-to-surface distance, or SSD, which represents the distance between the radiation source and the patient's skin. The Maynard F factor, an empirical correction factor, was historically used to account for SSD variations in PDD calculations. This factor relied on the assumption that the scatter component of the beam could be adjusted based on geometric considerations. However, this approach has significant limitations, particularly in accurately accounting for scatter radiation contributions. The Maynard F factor tends to overestimate scatter for large field sizes and underestimate it for small fields, leading to inaccuracies in dose calculations. The shortcomings of the Maynard F factor highlight the complexities of scatter radiation in PDD estimations. While percent depth dose, or PDD, remains a fundamental concept in radiation therapy, modern dose calculation methods have evolved beyond relying solely on PDD tables. These newer approaches, incorporating concepts like tissue-air ratio, or TAR, tissue phantom ratio, or TPR, and Monte Carlo simulations, offer improved accuracy and flexibility in dose calculations. TAR, defined as the ratio of the dose at a point in a phantom to the dose in air at the same point, provides a convenient way to account for the attenuation and scatter characteristics of the medium. TPR, similar to TAR, represents the ratio of the dose at a point in a phantom to the dose at the same point at a reference depth in the phantom. This allows for a direct comparison of dose distributions at different depths, independent of the SSD. Both TAR and TPR offer advantages over PDD in specific situations. For instance, when treating patients with irregular surfaces or using complex beam arrangements, TAR and TPR provide more accurate dose calculations compared to PDD-based methods. Modern treatment planning systems leverage these advanced concepts alongside sophisticated algorithms and computational power to generate highly accurate dose distributions. Monte Carlo simulations, for example, utilize statistical methods to model the transport of radiation through matter, accounting for various interactions and their probabilities. This approach provides a comprehensive and detailed representation of dose deposition, enabling more precise treatment planning and delivery. The transition from PDD-centric to TR, TPR, and Monte Carlo-based dose calculation methods reflects the continuous advancements in radiation therapy, physics, and technology. These newer approaches provide several advantages, including improved accuracy, enhanced flexibility in handling complex treatment geometries, and the ability to incorporate patient-specific anatomical information. By embracing these advancements, radiation oncology aims to optimize treatment outcomes by delivering highly conformal dose distributions to the tumor while minimizing the impact on surrounding healthy tissues. Precision lies at the heart of modern radiation therapy. The ability to deliver a highly conformal dose distribution, targeting the tumor volume while sparing surrounding healthy tissues, is paramount to achieving optimal treatment outcomes. Accurate dose delivery relies heavily on sophisticated dose calculation methods, such as those incorporating TAR, TPR, and Monte Carlo simulations. These techniques have significantly improved the precision of radiation therapy, enabling clinicians to deliver higher doses to the tumor while minimizing the risk of side effects. Tissue-air ratio TAR, like the PDD, depends on depth, beam energy, field size, and field shape, but is almost independent of SSD. TARs have traditionally been used for dose calculation involving low-energy beams, for example, cobalt-60, and isocentric beam geometry, for example, rotation therapy or stationary SAD techniques. Current methods of dose calculation use TPRs or TMRs, which have no limitation of beam energy and can be more accurately measured, to be discussed in Chapter 10. TARs for low-energy beams up to cobalt-60 can be measured directly or calculated from PDD. By precisely targeting the tumor, higher doses can be delivered, increasing the probability of tumor control and improving survival rates. Simultaneously, minimizing the dose to surrounding healthy tissues reduces the likelihood of acute and late side effects, improving the patient's quality of life. The advancements in dose calculation methods have played a crucial role in achieving these improvements. Furthermore, accurate dose calculation enables the safe and effective implementation of advanced radiation therapy techniques. Intensity-modulated radiation therapy, or IMRT, and volumetric modulated arc therapy, or VMAT, for example, rely heavily on precise dose modulation to achieve highly conformal dose distributions. These techniques would not be possible without the accuracy and sophistication of modern dose calculation algorithms. In conclusion, the evolution of dose calculation methods from PDD-centric approaches to TR, TPR, and Monte Carlo simulations has revolutionized the precision of radiation therapy. By accurately accounting for the complexities of radiation interactions and patient anatomy, these techniques have enabled the delivery of highly conformal dose distributions, maximizing tumor control while minimizing the impact on healthy tissues. This precision has translated into improved patient outcomes, including increased survival rates, reduced side effects, and enhanced quality of life. As technology continues to advance, further refinements in dose calculation methods promise to further improve the precision and effectiveness of radiation therapy, solidifying its role as a cornerstone of cancer treatment.